let's move on to the session number 2.
Professor Singh,
Yes, sir.
we've talked about technology for education, but I think we missed out on education for technology, because without,
I think we'll have to.
without this foundation at the school level and college level, I think our hopes of becoming a technology superpower will be belied.
In fact, my next question would have been encouraging, nurturing young innovators, core technologies. So that would have been the next topic.
They will, I think, send you the comments.
Starting at school level, I think what you mentioned that we have to really invest more than on roads. I think we have to invest on school infrastructure, because that's really going to be our future.
Can I make one short
No, I
point?
think
Research also is
જરૂરી નહીં
going to be a part of it. And we always talk about R&D expenditure and try to compare with international data. OECD countries use Rescati manual to classify what is R&D and how data has to be reported. We have no equivalent manual in the country. We have not adopted Rescati manual, and we have not devised any manual over even between various different departments of government. There are differences the way things are reported. So that is a big lacuna. So currently we have no yardstick for comparing expenditure on R&D with other countries and within various departments of Government of India. This also, TIFAC can make a note of it as how to proceed about it.
But as a percentage of GDP, I thought our investments are going down right now, not increasing.
Going
This
down,
is a major
and,
cause of worry.
and the way we classify R&D, there are deficiencies there, and this point has to be properly noted.
Okay. So, thank you very much.
I think that recommendation about higher investments must go.
You should, please. So, you are the in charge of the session. Yes, please. Sir, during lunch.
No, but now I will get.
I think please write it down and send. No, Professor
only
Yadav.
one
Sir, the
point,
second one is already here.
All right.
No, please write it down and send.
No, one
I'm sorry. Let's close the session. And Dr. Bhandari, let's welcome. Professor Yadav, sir, please. So,
I am saying that, look, I told this to Niti Aayog also number of times, that the CSR contribution should be increased from 2% maybe to 3, 4, 5% to take care of higher education, research and innovation.
बोलिए सुधाकर साहब.
I'd like to humbly submit our GDP to R&D ratio is 0.7. Countries like South Korea is 4.7. Your population is 140 crores.
141.
Sir?
141.
So 41, 42.7, whatever it is. If we really want to, if you are aspiring to be a superpower, the least that we make is make investment on ourselves. Why I say corporate social responsibility funds will not work is, we are talking about investment in strategic, deep tech and stealth tech. Let's not classify Zomato, Swiggy, Ola, Uber, those kind of developments that can come out of CSR funds. But any strategic technology...
No, I'm not talking about strategic. I'm talking of research and
both of you,
innovation.
please. Professor Yadav, let's move on to the health, which is more important than education, I would say. Yes, please. Bhandari Sahab, so let me introduce our moderator for session number 2, Dr. Mahendra Bhandari. He is the Director of Robotic Surgery Research and Education at Viticuity Urology Institute, and he is the recipient of Padma Shri Award 2000 and former head at the Department of Urology and Kidney Transplantation at Sanjay Gandhi Postgraduate Institute of Medical Sciences. Dr. Bhandari, my request is that 45 minutes you have. Thank you very much.
Thank you, Dr. Singh, for giving this opportunity for TIFAC to interact with such luminaries. In 45 minutes, with the permission of the chair, if I could use it for brainstorming and hearing everybody.
Sure.
We may not be part of the health delivery mechanism,
Up to you.
but you may be a recipient of that. So it concerns everybody, and most of the good points come from the consumer. In the opening remarks, let me tell you, with 56 years of being in the head, of which 39 years here and 17 years in the United States, I am not giving a lopsided view. One first point I would like to clear, don't be under the assumption that delivery is equivalent to receipt. last mile is equally important. Our group has come out with a data that why African Americans have more advanced prostatic cancer. It was being considered because of the genetic factors. No, it is because of poor access to the health. So India don't have a data, but not that it's not happening here. So please consider that data is good as long as you can trust it. But more important is like going to the periphery and checking what is exactly happening. There should be a mechanism for that. Second is total focus. I have been seeing Ayushman, so many schemes. They are all focused on absence of illness. It is not absence of illness. A mile apart is the positive health, and we are talking about wellness. Because absence of illness needs enormous amount of research, resources to bring your, if you are a diabetic, I can bring your glycated hemoglobin to normal, but there is an extra effort to keep it normal all the time without medicines. So second caveat, my dream is that India should consider, and third thing is, I am little a contrarian, that what you are not the judge of it. People have parameters to come and check and do that. So I think if we do our job well, we would be where we want to. So I'm not really focused on data, and that is very good for local diaspora, but it doesn't work for international level. And third thing, what, sir, I would like to say generic, whether it is health or education, I don't mistrust the data, but people should trust our data. And what has happened to Chinese, I don't want to take too much of time, that they have really played the game well during COVID. I was in China a month before this happened, and I could see in the Nikkei meeting, which is the largest computer imaging meeting, they had algorithms for chest tuberculosis diagnosis. But what they did was, during COVID, they had millions of, they used that ground truth to use it for COVID algorithms. Most of their publications were made trustworthy because they were either with Oxford's partnership or Harvard or Hopkins, because they mitigated that thing, because these institutions would be a ladder for them to climb high impact journals. Yes, and two things. I never thought while I was in India that we have problem of resources. It is a problem of resource management. And what I would like to say is not important to have resources, more important to have abundant mindset than scarcity mindset. I went from here with the scarcity mindset, not that suddenly dollars poured in, but I got into a group which believe in themselves, and they believe that resources will flow if there are ideas. So with this, I would like to say something at the end for 2 minutes about my own discipline, how technology can play a major role. But before that, I'll request that please, we should like to listen to as many people as possible in the given time, provided we are brief, crisp, and don't repeat and emphasize, because this audience is intelligent enough to understand the question. So if you are brief, begin from wherever it is, please.
Yeah.
Any one point what you dream the healthcare should be by 2047.
Right. First of all, let me first say that Dr. Bhandari is my good friend, and I have highest respect for leading robotic surgery in our country. But and as he agreed with that what we need in the country is more generalists, general surgeons, rather than super specialists. That's the reality. So I come from a small town. Indore is not that small, it's a big town. But I understand the needs of the people, as Dr. Bhandari also would need that, understands that. So, as a thinker on healthcare needs of the country, I think what we need is more generalists rather than super specialists who can work, who can do all kinds of work, and of course family medicine as a super specialty. Primary care should be given the right kind of recognition both by the society as well as by the medical profession. They are at the lowest level. All the medical students nowadays would like to become like Dr. Bhandari or like Dr. Devi Shetty. But that's not the need of the country. The need of the country is a good family physician who can look after right from childbirth to the person in the family who is dying. And that we are neglecting it. And that for that the society is also very much responsible. For everything they would go to a super specialist. For every little bit of illness they will go to a tertiary care hospital. Because of course the medical profession has failed as well. We have not demanded that a family physician or a GP should be considered as a specialist. That's what has happened in the countries, even in the developed countries like UK and USA. They have realized it, that the COVID-19 has given lots of key lessons for even developed countries, that they realize that I wish we had much more general practitioners in our society rather than a specialist. We wish we had a better, robust primary care in USA during this COVID period, and they have realized it to their, though they started changing from 1960 onwards, where they made internal medicine as a specialist, family medicine as a specialist.
Sir,
But even then, sorry, these are my reactions, and I'm sure Dr. Bhandari will agree with that.
Yeah. There's absolutely no question of agreeing, but at the same time, I'll make your job more difficult. Today, if I have to get treated by somebody, he may be a specialist or generalist, but the quality of clinical sense is the most important. So, by generalist, I certainly don't mean the currently MBBS outputs. If you include clock, you are so true, sir. In United States, family medicine is now the most difficult specialty to take. In institutions like super specialty like Sanjay Gandhi, we realized in the model that we need an integrating medicine. Otherwise, if I tell you, you don't have a kidney disease, it doesn't help you. You are asking, what do you have? Please. Yeah.
Okay.
I'll request one thing, sir. Please go ahead. But if you give one tagline to it,
Yes,
and then
I'm
I can
going to
request
do
you
that.
for a big note on that.
Absolutely.
It will help the doctor.
Absolutely, yeah. So, being a clinician as well as who dwelt in technology at various places and after working in India and other countries, what I personally feel is what is the need of the future is the capacity building. You know, our doctors who are coming out of most of the medical colleges should be made, technically capable to use the modern technologies so that we can economize our, so second point is how do we economize our health care? It's a vast country and we don't have the resources. So how do we reach the last mile with minimum expenditure? So we can save a lot of money, yet we can go to the masses. And I think the best way to do that is, how do we sort of align technology with Indian ethos, like the Ayush, that is our traditional medicine, allopathy, that is the curable part of it. Curable part is always very, very, cost intensive. Whereas preventive, our medicine is, less. So how do we, bring a synergy and use technology to give it to the people? So this is my second, the advice. And the third will be, the environmental and climate challenges. We have a lot of climate challenges like drought and cyclones, floods, and that really changes the entire health, aspect of the people. So, lot of infection and all these, injuries, traumas. So that's a very major issue. Like we all know what is going on in Joshimath. So that is one concern, and environmental toxins. Our communicable disease and our non-communicable diseases both are linked to environment. So all microplastics, toxin, gases, and the pandemic has really taught us how environment is important, this slaughtering of wild animals and all. So I think these are my concerns, and I leave it to you all.
Thank you so much.
Thank you.
Yeah. In the last session and this one thing I observed that we are still thinking today's technology. In 25 years, think how the mobile phone has changed. While we are talking to the children and using it to play games, why are we not using the games to play the children? Healthcare is not about the environment or the access or anything. It is about behavior. Today, the largest killer in India is not infectious disease, but non-infectious diseases. The lifestyle diseases, so-called. Now, as sir mentioned that disease is not merely the absence, health is not merely the absence of disease or disability, but that is all that resonates with India today. WHO 75 years back defined health as a state of complete physical, mental, social, and economic well-being. And then they said not merely the absence of disease or disability. So, technology will develop 25 years down the line. Sir said many of us won't be there, so possible. But the technology will be there. 25 years, that cell phone which we now see in the museum, and today what we have a computer in our hand, is going to change. And neural networks, brain neural network interface, all is going to happen. There is no way. Elon Musk is not just blowing air. It is going to happen. Question is that can we visualize it? Charu ma'am made an excellent point that maybe we need to think as children. And only children can believe in magic. That was the other point.
Okay, so as somebody who has dabbled a little bit with making micro devices or technologies for which can assist doctors, one thing that we face is not having enough samples to test these technologies with. So I think there is a need for some sort of an agency or some sort of organization which sits in between the technologists and the doctors and provide whatever is required on both the sides. That's I think that's the only point which I would like to make, that is important. Really, it's not that the innovations are not happening, it's just that we're not able to take it to the next level because of not having this access to samples.
Yes, please. Sir, I would like to pose two important points. The recent pandemic has posed an important challenge about how we can provide an affordable medicine to the last people of the society. So, if I look at it from 2 points, that we need to really make an investment in the R&D. We have to increase the investment in the R&D and high-end technology in the pharma sector, so that we can reduce or minimize the import. Largely, if you look at the API, heavily we are depending on China. So can you think how we can minimize the import of the API so that medicine works? My second point is that can you think about digitization of the national health system so that people who is sitting in the rural area, if we get ill or sick, we get a good healthcare facility through a digital of the national health system.
Okay.
You want me to?
My point
Yeah.
of view is not related to the medical fraternity.
paracetamol and metformin to build bulk products now today. We are totally dependent on China. There's already been a think tank that started about 10 years ago, but we've not really seen that throwing up the benefits. But I think this is something that needs to be taken very seriously, because in 2047, with the most advanced technologies, we may not sustain our good health if we don't have access to these basic medicines. So China dependence and import dependence should certainly be one very important focus area that for sustained health of the nation we need to focus on.
Yeah, I have a different take, because as we advance into future, everybody will have personalized medicine. The same Tylenol or Crocin will not be required. So if you have a genome database, your sex, your health condition, environment, you will require different type of formulations, and the same off-the-shelf thing will not work. So you have to have a lot of database, AI to be made use of for everybody, because everybody, even in the villages, will have these mobile phones, and every kid will have it. So why not provide that facility? So these generalists, you go to the generalist, he gives you 4 tablets, you don't know why he's giving. One is yellow, one is blue, one is pink, and you take it. They never tell you which one is to be taken first. Will there be a drug-drug interaction? This kind of knowledge does not exist. Therefore, in our medical profession, if we are going to produce good doctors, this is very, very much, because we may be 2 billion people by 2047.
So I have another point to talk about. For the kind of population that we are in, that we will be, it will be next to impossible for the country to be providing hospital rooms. So we need to be using the technology which is coming in 5G, and we'll have to start working on 6G right now itself. So the pre and the post procedures should be done at home. So how to convert rooms at home to a hospital room for both these purposes and use technology for that. So any kind of a diagnosis can be done at home if you are able to develop technology. And it's already getting developed, and India need to be taking care of that, because it's impossible for us to be looking at this as an aspect. And in any case, COVID time, we have learned it also. Many of them had, there were companies who came with converting a room into a ICU equivalent of that. So this is an area where I would request that the country should move forward and technology should be put to use. And the hospital bed multiplication is not the answer for India.
So, we are talking about 2047, which is 25 years ahead. So today when a child comes to 11th standard, they wonder whether I should go for engineering or medicine, 2 distinct streams. 2047, it may not be 2 distinct streams, it may be 1 single stream. Quite a possibility, and there are reasons for me to believe that. And best practices would be, there is a professor from IIT Bombay, Professor Ravi Balmudi, who does this medical device hackathon year after year, bringing the doctors and engineers together. We have the best engineers, best doctors, but they rarely get a chance to work together to solve a problem. So that is one capability building that we consciously should do, so that these 2 streams can become 1 stream going forward. Second is, of course, my alma mater, IISc, Indian Institute of Science, is building a medical school now. I'm sure almost all IITs and IISc will have an in-house medical school, so that those interactions will become more frequent.
One point I think, I recently heard a talk by Vinod Khosla, who is a multi-billionaire who funded a lot of health tech startups, and he believes that the doctors will be redundant sooner or later. I mean, at some point, all the primary health care part of it, he believes, will be taken care of by machines, and even the prescription of medicines also will happen by the machines. So he believes doctors will be basically to counsel and things like that. Of course, surgeries, will require to be done, and there maybe robots will also come in. I think the doctor's role probably will be very different by 2047.
Artificial intelligence and robotics. The medical scenario, I'm not a medical doctor, but I'm running a physical super specialty hospital also. The World Health Organization only a few years back have said that in India, in every family, there
they have to be a cancer patient. Now that is a diagnostic and the technology portion has not been thought about by the medical community. So when you say that our doctors and the surgeons would be redundant with the application of artificial intelligence or robotics or machine learning, it's very difficult to foresee, because that is the same point I feel in this 2047 should be underscored. At the time, in what time frame we are talking about this, a few minutes back it was talked about this GDP difference, education. Similarly here, when we are going for health, one stage to another stage we are making a specific application. Say we have made certain oncological surgical intervention or radiotherapy, but that may not be applicable as it goes on changing with more infection, more, I should say, we have seen in COVID how it is changing. It is mutation several times and very fast, which you won't be able to cope up. And there I feel the basic knowledge of the doctors and the medicine will always remain. You cannot divest the work of a doctor, a medicine, or an engineer to be divested from the purely from artificial intelligence and smart telephone and robotics. I think that is too much to it. And we have to come for that. I just wanted to introduce a simple telemedicine in my hospital. It's a fairly in a rural area. It is difficult. In the last 3 years, I'm struggling to introduce the full-fledged telemedicine, not to speak of robotics. I've not been successful. Similarly, when you go from the full-fledged robotic surgery in cardiac or in oncology, it's a totally different game. It would take miles, years, many years. And we can then, by that time, we say that none of us will be in 47, will be there. So whatever we have said, it doesn't stand valid. Thank you.
Yeah, so I have a very different take. I think our topic is how can India be a healthy country by 2047 with everybody being healthy, enabled by technology. So I think that's the fundamental thing. I personally feel we should look at controllables and not controllables very clearly. There is no point discussing things which are not in our control because they will reach us nowhere. We have enough brain power and skill available over here to look at the controllables. So that's an important part. Second, very important, so let's not predict what technology would be in 2047. I don't think, I'm sorry to use this word, but any joker in this world can do that. Yeah. What is necessary is concerted and coordinated effort. We have islands of brilliance sitting in India, whether it is technology, healthcare delivery, use of technology in accessibility, you name it, IoT devices. There are pockets of brilliance across the board. But are they all talking to each other? Is there a concerted way of addressing the problem? I don't think it's a resource issue. I think it's a coordination issue. It's a networking issue. That's point number 2. Point number 3, and I can write multiple paragraphs on this and maybe email it to you. The third important point is when we talk of technology and healthcare, we should always talk of connected healthcare. If we want to leverage technology for better health of individuals, and connected technology has to be looked at from 30,000 feet. A district has a PHC, CHC, district hospital and stuff like that, right? Can I go to 30,000 feet and look at India and see how can I connect every healthcare delivery center with every receiver of healthcare? Mobile phones are there. We can talk ill about mobile phones, but let's not forget the power of mobile phones today. There are apps which are driving health. There are apps which are driving adherence of certain treatments, okay? Second very important thing is, next important thing, not second, I've already said 2 points. 60% of healthcare in India is delivered by private players, right? They live in their own 4-walled hospital. They are not concerned what happens outside for very obvious reasons. They have investments, or debts from outsiders who want return, and debts have to be paid through EMIs. Do they see an incentive in going digital? I'm sorry, no. I've been in healthcare for 36 years. I have seen a 10-bedded nursing home and a 3,000-bed hospital, right? So it doesn't happen. I mean, we can discuss here, but let's involve, I think whenever we have a debate like this, it's very important to involve the healthcare deliverers, because if they don't adopt technology, technology will not enable healthcare delivery. So that's another important part. Plus, I think we have enough resources, both technical as well as medical. Can we leverage every resource in a concerted manner? We have Ayush doctors, we have nursing specialists, and we have the allopathic doctors. Can we create a pool and create a network as to who can do what? There is an effort in that direction. There is an effort in connecting everything in India through ABDM, all that is happening, but I think much more needs to happen. I don't think we should worry about what we don't have. Let's look at what we have and how we can leverage, cross-leverage everything together. I think that's extremely important. Thank you.
I couldn't agree with you more, really. And only thing which helps in our country is government rules that you please share your EMR with your other hospitals as well. There are enough resources, as you rightly say. So private sector plays a major role. What stops private sector to participate in medical education, main medical education? The government is always saying that there are shortage of doctors per thousand population. And somehow or other we are making it towards that goal. But the planners, the administrators, they think that having more medical colleges would be the answer. So that's why we have the largest number of medical colleges in the world in any country. And as you know very well, Flexner's reforms which had started in USA many years ago, and there were also so many medical colleges, and gradually he reduced that number, much to the hue and cry of the private sector people. And even then, they have a much better kind of doctor population ratio. Now that their health care is broken, that's a different matter altogether. So why can't be the private sector hospital which are capable around the medical colleges can't participate in main medical education system? By that, you can increase the number to 4-folds, without any expenses. So next to the grand medical colleges, there are huge medical institutions in Mumbai. So why can't they be? That is one part. Secondly, of course, that the only thing which people realize is, at least in India, is that there is a government rule should come in that you should share your information with the next door hospital or one who is in your chain. They won't even share that information, saying that under, it's patient's information we should not share with you. But this is population health.
Correct.
We are talking about population health. So if we are talking about longitudinal care, we are talking about care which is patient-centered. So I'm sure the patient would be very happy if his information in the hospital is shared by the family physician who is caring for him. Okay. So that is one aspect. The other problem which somebody had said, that the technology may remove the doctor from the AI, 80-20 doctor, and the 20 will be the doctor's work and the technology will be 80 work. But the technology will take up all your uncertain work of doing more investigations, trying to find out what are the drugs are which are interconnected with it, or which are that's not going to work with you, that all will be taken care of by the technology. And all you have to do is to do what you're supposed to do. Be compassionate, be in touch with your patient, and provide that kind of help which you explain to the person that this is your investigation report and this is what I have come to, the diagnosis is such, and this is I'm going to do this. And so the technology replacing the doctor will not take place. It will only help the doctor.
If
and
I may...
and the third part is, of course, the technology will be best used in population health, in population education, in doctors' education. And that way, and the technology which is used by the medical profession as such, in robotic surgery or whatever, in genetics and all that, that is a different technology altogether. But the best use of the technology will come in population health improvement. That's what I
Less than 30 seconds. The disease burden will increase with advancement. They will see new complex diseases that you have never seen before. So therefore, to try to address that, we have to build the infrastructure to be able to take care of those surprises. The whole world was not ready for COVID, right? And we learned through the COVID. But having learned through COVID, can we learn over the next 5 years? Let's not talk 25 years. Nobody knows what's going to happen after 25 years. That's one point. Second important point is that we are talking of education and health, and allow me to bring education because medical education is a part of education. There are agencies like Khan Academy and some very good education startups. I'm not talking about the Baijus of the world, okay? But I'm talking about really good educational startups who are doing visual tools to impart education to schools. And I've shared a video with Professor Malhotra on how 55,000 schools adopted technology in interior Maharashtra. Just have a look at that, how we can combine the education reach for medical education between the two agencies.
Yeah. I thought I'd just take a slightly different sort of point here. I think key to medical technology is research. And I think that is one of the great lacunae of Indian medical research. It's extremely low rank. There is not much research going on. And the main reason for that is that doctors have absolutely no time to do research. I mean, if we need we need some policy change so that doctors can be both part-time clinicians and then part-time researchers, so that they spend at least...
They're not trained to research, sir.
No, there are many who are absolutely capable of doing research. No, not most medical. Those who are professors, they are absolutely capable of doing research, and they are, but they have no time. Early in my career, my first paper, in fact, came out in British Journal of Plastic Surgery, working with some surgeons in KEM Hospital. And, I was very horrified to find that they would have maybe 1 hour a week or 2 hours a week to devote to research. And that, it shows up in our overall performance in research, because it's really impossible to come up with some new research programs which are significant when there is such a shortage of time. So this requires a structural change to make sure that some doctors, or at least those who are researchers, are given sufficient time to do research beyond their clinical practice.
Yes, Dr. Saini, please.
Yeah. Good afternoon, sir. Actually, as Madam has suggested us that we are dependent on China for drug intermediates for developing drug therapeutics. However, we are first and topmost in the world for developing vaccine therapeutics. Whatever we have shown to the world, that like Serum Institute of India and Bharat Biotech they have developed Covaxin and Covishield. So the problem is the same problem is residing, or we can see whatever. I have been working in COVID for last 3 years through our startup in IT Bombay. So we have found that we can develop the test, but still most of the more than 99% companies are dependent on proteins which are being used to coat into the membrane for developing the test lines and control lines. So similarly for drug intermediates, we need to actually develop our strength to manufacture develop the in-house manufacturing facility for proteins, antigens. If China if someday China denies us to not to give the proteins, then most of the companies will shut down. Thank you so much, sir.
Can I make one short point? We have talked about doctors and the research. There are healthcare professionals at lower levels. No talk about that so far, and they are very important and doing a lot of work. In this regard, reading articles, I find that nursing staff in other countries, particularly UK, they are allowed to dispense with certain medicines, do certain preliminary work, while in India it is not allowed. To build capacity, isn't it better that we train nursing staff also to do certain preliminary kind of work? I'm not a doctor, so maybe those who are in the field, they can examine it. If it can be done in UK, it can be done in USA. Why not in India?
To the same, may I add, that we do not have certified paramedics. I think our doctors will say that. So when in an emergency, in any emergency situation, an ambulance goes, our ambulance system, transportation, because when we talk about health, we can't just take off one person and that person's health. All are these allied, and they all come together in order to deliver the service, the health sector. Ambulances are not properly coordinated, so you will find that ambulances do not come. We talk of the golden hour, all the doctors who are present, or even some of us who have got into emergency medical services for civil society. What do we see? That we are not able to give the first aid. There is no training system here. So if we are not going back to education, which I mentioned, if our foundation is not strong as civil society, the rest of it will come in. So technology should ideally also address this very big lacuna that we have. So here we go with the paramedics. People loosely call people who come in the ambulance as paramedics. We don't have legally that. So a life-saving drug cannot be administered by the person who comes in the ambulance. So can you imagine the amount of time that is lost to save a life? It's a simple enough thing, but we still don't have it. Our training of emergency, in abroad, you will have every second person knowing CPR. Here do we know? May I ask then in IIT, how much of that has been incorporated? And I'm not saying it loosely. This is something which we went to check on this factor, and therefore I brought this point out, because whilst we have the higher side being a lot of talk going on, but at the base level, there's a huge, big missing slab. Civil society is not looked at. I am speaking from that point of view altogether. The layperson must be made capable of dealing with things. More and more technology will come, and as we advance, our earlier systems of support is not really going to be in the same way. So then how are we equipping each one of us to take care of certain things, whether it is health, whether it is helping others? And COVID showed up all these aspects, and we have not learned from it, or we have not yet given the focus to it. So we should, ideally, we should look at also mental health, which we talked about. I brought in a little bit, but COVID showed us how, because we were all in lockdown, we couldn't help each other. I personally, I'm not a doctor. Okay, somewhat of training is there, but of helping in emergency situations. We had overdoses with people in societies. I'm talking Mumbai, we're sitting in maximum city, and we had maximum problems of this kind. We all went to COVID, we forgot that there are 100 other things that are there. So I think a balance needs also to be built in when we are talking technology. Similarly, what we also noticed, and I bring this because information is also one of the subjects, but when we are talking technology, ethics and correct facts being given to public is hugely important. The amount of fake news with health in particular,
the misinformation that is across the board. So with technology comes a huge bit of ethical responsibility. I think that has to be built in. I say this completely from a layman's point of view, but I lay it out there for you all.
Please. We want
Thank you.
Yeah, thank you. Just 1 minute, please. Yeah.
Like from students' point of view, like I might be totally wrong, but still, like in the previous slides, I saw that the aim was HDI having like being in the top 20, and then the basic things related to HDI are like we see the life expectancy of the person, like how much years they live, the schooling, the earning. So as even like Uni Krishnan sir, he said that the parents, they are more concerned about the individual studies, like if the person will be able to earn or no. So we don't even see here, like if the country has the population and poverty. Like on that case, like if we see India, we are at the top, like population wise, and the countries others like which are above us in HDI, they are like Sweden, Switzerland and all. So they don't have like so many people, but still like the resources which they are using and other things, they are more like using it in terms of health. So that's why they are better than us. And even if we see the vision for like next 24 years, like previous 24 years, I wasn't there, but I have heard that there were no mobile phones, like even with the urban class people and even the rural class people. But now, if I see, there are people, everyone has technology, even phones and all, but the usage, that's not optimum. Like even I've seen my maid, she has a phone, like all are exposed to technology, but they don't know where to use it. So I think even if after 24 years we see, so people might have the new technologies, but they should know like where to use it. That's.
Yes, tell me some.
Just one point, the role of insurance in medical treatment. In the developed countries, we see insurance dominate a lot, the hospitals and the deliverables. And whether it is good for India for the future or not, that is a debatable point.
I don't think there is a debating point. I think they should. And both the yojanas, government yojanas, as well as insurance company, the payment is for bad health. That means you reach the hospital
For me.
when you are at the last stage, then I will pay you. The yojanas are like that. And so the insurance company as well. Even for small procedure, you will have to stay there overnight so that they can pay you. And both the insurance company as well as the hospitals are hand in gloves with that. So I think you should be paying for better health rather than for bad health. So someone like physician, a GP, who looks after you well and who doesn't have so much of reference to the hospital or to the consultants, he should be paid well, provided there is a payment system involved in that. And that is what has happened in UK as well. There is an incentive for a GP group practice. If you have less reference to the hospital, you are paid better in the next year annual income.
Thank you. Dr. Bhandari, only 2 minutes and 3 slides, I think.
No, 5 minutes I reserved for me. So I'll have to wind up.
Lunch is already ready.
Yeah.
So do not complain that the lunch was not good.
5 minutes, 3 minutes more.
Okay,
not that
please
I
go ahead.
usually
Yeah.
don't talk too
Go ahead,
more.
yes.
Thank you very much for all these inputs, but there are few points I need to address. Number one, on a positive note, looking at the healthcare system, not just slides when I tell you. Please.
Okay, please.
Positive note, India has a real opportunity, I believe, to create an ideal healthcare system. Because the chaos, NHS, United States and Canada, only God can bring them out. Costs are soaring up, accessibility, and even European system is not. Our 70% system needs to be reorganized. So I think we have a great opportunity. There were lots of good points on competition between technology and human side of medicine. Let me very clearly say they are complementary, not technology can at the most act as an enabler It can never replace human beings, which your cars have shown that level 5 is out of the agenda for our age. So I don't think, and then third point which I must address is of the apprehension of technological trajectory in next 25 years. If you're what you call the vision is very clear, which I'll show in this. Whichever technology comes, it will be simpler over a period of time. There was one point made, I wanted to make a comment, but I brought it on medical education. Having set up the first medical university in the world with Apollo in 2000, Medvarsity, when chairman had a vision, I taken a leave. At that time, I learned computers, and I realized that what I learned in medical education content is ideal to be taught with technology. We brought CAD/CAM tools, sectionings, rotational graphics, and technological things, check your understanding, spiral education which you have used. So I think in education or health, it should be included medical technology, which is the very complex thing to explain. The cadavers are a very poor way to teach medical education. As regards to the, yes, having spent 17 years, I feel very strongly that if the world has to learn one thing from India, is the human side of medicine. Most of the complex problems were not solved in my career by investigation, than listening to them for 2 hours. So I would say that don't forget human beings have a mechanical body. Part of it we understand, part we don't, but they have a psyche also, they have emotions also, and somebody needs to address that. With this, most of them we leave to investigations and read the reports and treat the report with no correlation what would be the outcome to the patients. I'll just show you 3 slides, please show. This is to scare you. Lowest quartile surgeons have 36% higher complication rate. This is US data. Indian data, I wish I don't have, because there is no data, and if it is there, probably you would shirk getting into operating room. This is the grand reality. And sir, I read Vinod Khoshla's presentation is with me. I take it in positive, right? I am not radical like C.K. Prahlad said, or that technology can take over, but I can say that we can realize the shortcomings of the medicine, which would be prompt us to use technology to overcome these things. Surgery does not go as planned. We have operating notes universally, surgery proposed, surgery done, simply because surgeons have least predictability. One action of mine, what would be the reaction of the body? Nobody knows. And that's where we want to use technology. And then it's mind-boggling why technology is needed. In US, there is a data to show 60 to 70% of the people are needed to bring a desired technical outcome. Forget about how the patient will do, but to do an operation well, we have to do that. Next slide, please. 25% of the error in UR are technical errors, and 75% are human errors. And we can address them with technology, as we have shown with the robotics. And these are the subsets which everybody knows. Next slide, please. And now, you're talking of technology. Can you show me the next slide, please? Yeah. We conduct a global innovation competition, and this year's competition award, out of 100 top submissions from 76 countries, went to Cleveland Clinic on what? That kidney transplant patient is discharged within 4 hours of the surgery. We have to think of that, because that is ideal. Here, the technology robot costs $2 million is decided by the balance sheet of what would be the rate of return. This is stupid. Something which will take 20 days resources, we are still counting our healthcare in terms of number of beds. I would be happy. Efficient healthcare systems would have no beds. And that's why I would like to say this was done with a single port robot, Now go back to the previous slide. How many surgeries? 100% of they leave on the same day. Look at your resources you save. Look at the families and non-medical expenses. 5 members in an Indian system is with the patient all the time. They don't have resources. They travel from all over. So we are talking of cutting costs across the board, not only in healthcare. So I would emphasize, don't judge technologies simply because they are expensive. Judge them with the outcome and value they bring to the overall patient outcomes and gives them more satisfaction to patient. I think one more slide and I'm done. So I think I'll end by telling the surgery, first thing is the safe. Any one of us could need surgery and we would like to trust surgical system. As a surgeon, I don't trust, but I wouldn't like that to happen to everybody. Predictability has to be there. A mention was there on predictive models. These are, they look very good. I have 6 papers on predictive models. If anybody wants, I'll give you the details. Big data predictive models. We were hoping that our models would perform 99.999 as Tesla model performs, but no, we were wrong because healthcare data so far is not conducive for predictive modeling. We can bring areas under curve, but you can't deploy those models with confidence. Why this happens? One single difference is we don't have a real-time data. Tesla generates 2 million cars data every minute. We don't have that kind of thing. So India-like country can really rule the roost if we have large volumes and we exploit them in developing a data culture. Currently, we are possessive of the data. Neither we are using, nor we don't want to use anybody. We don't know. EMR and EHR data is not conducive for big data analytics and predict. And I think this is all I would like to say. Thank you very much for letting me speak. I hope I covered, but I wish this session would have had one full day in order to take everybody's views because they were very, very really probing
Dr.
views.
Goswami to take a call on this and.
Sir, as a part of the process, second level intervention is deep down of each sector.
I think everybody should be, there is nothing pressed. Everybody should be given an opportunity.
Let us give a big hand to Dr. Bhandari and Professor Rao. And see, fortunately we have saved 20 minutes. Now we are only running late behind by 40 minutes.
Not accounted to me.
No. So with a request that please join us for lunch.